Good afternoon. So see, it's raining outside. What better place to be than here at Heart to Heart? So welcome to all of you for my very last Heart Talk with Cathie. And I'm so honored that it gets to happen here on the Heart to Heart stage. But more importantly, I started my Heart Talks with my dear friends and colleagues from MedAxiom way back in April, right after convocation last year, when I was sitting in Chris's chair. And we talked about dyad leadership, and I had my day job dyad leader with me. And I'm so honored to have my night job dyad leader, Chris Kramer, with me for this, our last Heart Talk with Cathie. Chris has been the most amazing dyad partner, as you all know, heading into this role. Never quite sure how things are going to unfold and such, and Chris has just been remarkable. So Chris, thank you so much for being a great dyad.
And thank you, Cathie, for your inclusion and including me in all of the work we've done over the last year. We've come a long way and a lot more hurdles to jump over. So I look forward to your dyad help over the next year as well.
So we see what Chris doesn't know is I really started talking about this transition about 2 days after I started as president. But see, we're in Chicago. And so people think tomorrow at the convocation that I'm going to hand the chain to him. But I've decided to change the rules. I'm thinking maybe I'll just stay another year. No, just kidding. You know, we are in Chicago, so we could change those rules. So what Chris and I were thinking about as we decided to do my last Heart Talk, his first presidential talk that he'll kick off right after convocation tomorrow, is to take both of our themes and sort of tie them together. So as you all know, leadership, quality, teamwork were my focuses for my presidential year. And I think combined with Chris's focus on innovation and mentorship, it was just an ideal time to really tell you what we think is important in our hearts as we continue to grow the college. And this is not supposed to be us up here doing blah, blah. So please come up at any time. We're really good at interrupting each other. We've learned how to do that really, really well. But maybe, Chris, we can start off by talking about teamwork, because I see the CV team is over there bustling around, obviously something I've been talking about both nationally and globally. What have you seen this year as it relates to teamwork? Have we made a difference?
Yeah, I think there are a lot of examples of teamwork in the college. I think an important one is teaming up of the ACC and MedAxiom, which of course is part of ACC. But MedAxiom focuses on helping healthcare institutions and practices, and including academic institutions, improve their quality and transform care. So that partnership between MedAxiom, the ACC, and all of our members has been really important to move things along, especially in the areas like the new ambulatory surgery centers that MedAxiom is helping to, through its MedAccess program, helping to stand up around the country.
Well, and I think the other thing that's been remarkable, if you haven't noticed, I think about 2 weeks ago, we published the very first care transformation, because, you know, one of the things we keep talking that we have to do care delivery differently. But Dr. Ami Bhatt, who is in charge of our innovation, and Ginger Biesbrock, those of you that don't know her, is the CV team extraordinaire. And they actually published an article, a process for transforming care, which I thought was pretty illuminating. And I think it's just the beginning of what we need to do together. And I think our state and international chapters are also a pretty good example of leadership. Tell me how innovation, do you need a team to help with innovation, or what are you thinking about innovation?
Yeah, I think innovation stands out through all we do. I think to your point of the state and international chapters together, I think many may not be aware of the twinning examples throughout the state there. I think there are upwards of 10 state chapters now that twin with chapters around the globe. For example, in Virginia, we twin with the UK. So some of our members go over for the British Cardiac Society, and members from the British Cardiac Society come over to our Mid-Atlantic cardiology meeting, ACC meeting, and visit some of the local health institutions. So there's a lot of collaboration, teamwork, and innovation. And I know Illinois, you twin now with
Guess who?
Ireland.
Ireland. I had nothing to do with that whatsoever, but I was so excited when Ireland was announced as our new international chapter. The bagpipes might have given it away a little bit yesterday, but absolutely, I've had bagpipes twice in my life, at my wedding and here at ACC, so the two most important things. But as we talk about teamwork, and we look at sort of our global audience as well, I hear there's some exciting things coming out of the United Nations that you've been involved in.
Yeah, so I had the honor of participating in the UN General Assembly this past September to really get things geared up for 2025 UN General Assembly in New York in September, where non-communicable diseases are going to be the focus. So trying to reduce the incidence of the number one killer in the U.S. and around the world. There's the World Heart the World Health Foundation is going to be meeting in Geneva in May to plan for the UN General Assembly and the discussions around how we can get countries around the world to really focus on non-communicable diseases. A lot of the focus for many of the major philanthropies, the Gates Foundation, et cetera, has been in trying to reduce infectious disease around the world, which of course is very important, but you can't forget that cardiovascular disease remains the number one killer, even in those countries where infectious disease remain important killers.
So before we leave collaboration and teamwork, maybe one of the best examples this past year has been our journey with trying to form our own board, ABCVM, with our professional societies. Tell me how that journey has been and what we've learned from that journey.
Yes, I think it's a great example of our ACC coming together with the other cardiovascular societies and subspecialty societies. As everyone I'm sure is aware, the planning of the American Board of Cardiovascular Medicine was a collaboration between the ACC, AHA, HFSA, SCA&I, and HRS. So those 5 societies got together and put in an application to create a new board of the American Board of Cardiovascular Medicine. That application went into the American Board of Medical Subspecialties back in January of last year. There was a long review process, and unfortunately we heard just last month, that the application was not approved. So we're now thinking, the board is thinking about next steps and where to go from here. There are a number of possibilities, but I think more importantly, it shows how cardiovascular societies can team together to do important work and work together at a common goal. So often there's discussion about how societies may not be working well or optimally together, but I think this is an example of where we're moving in the right direction altogether.
Well, and I think, remember, you have to ask us questions, otherwise this will get very boring. But we've also had 2 very interesting meetings today, one with our colleagues from the European Society and one with our colleagues from STS. What did you think about those meetings?
Yeah, I think it's, again, examples of where we have a lot of room for growth and where all parties are interested in working closely together. I think there's about to be a joint guideline between the ACC and the ESC on the care of master athletes. So that's a first step amongst many potential combined guidelines. There's also a work group between the ACC, AHA, and the ESC working on how we unify the way of keeping embargoed late-breaking clinical trials, because there have been examples at different meetings over the last few years where industry has released top-line data ahead of time, and different societies have reacted to that differently. Some, including ACC, have prevented the presentation of that abstract when there's been an embargo. Other societies have kind of let it slip. So I think we're, again, working together with other societies to unify. In terms of the Surgical Society, we are deciding to kind of rekindle our relationships with them. They were slowed. COVID kind of got in the way of the pandemic, got in the way of working closely together with them, closer on guidelines, closer on working with industry, CMS, the FDA. So we had a meeting this morning where we've decided that we need to work closely together as the heart team, and really because many of the procedures we do now are in collaboration and not in competition. So we're taking a patient-oriented heart team approach to working with our surgical colleagues.
Excellent. So as your incoming president in maybe 30 hours or so, what advice do you have for new leaders? How can all of these wonderful people out here get involved with the college? What's your recommendation for leadership within the college or in your home institution?
Yeah, I think there's so many opportunities now in the college. It seems like they grow every month in terms of leadership courses, leadership programs, the Sandy Lewis mid-career women in cardiology leadership, the national ACC. Many of the state chapters now have leadership programs. So there are so many opportunities for early and mid-career members to get involved, to learn how to become leaders, which helps not only at a national level, an ACC level, but helps you at your own home institution as well.
Still no questions.
Well, we haven't really asked. So please come to the mic, and if you have questions for both of us or either of us about teamwork, collaboration, innovation, leadership, or the direction of the ACC, please.
Or how you have employed and enacted teamwork within your practice. I know I just came from a couple great sessions downstairs. One of them was on site neutrality, and the other one was on the evolving models of our cardiovascular employment. So we can see that this is all changing. And you're a master imager. What kind of things do you see as AI comes into the world, and how its impact will be on our clinicians and our teams?
Yeah, I think AI has impacted us already, beginning several years ago. For analysis of cardiac MR images, beginning 3 or 4 years ago, the software that we used every day now uses AI approaches to do quantification of our volumetrics. So data that used to take one of our fellows 20 to 30 minutes to analyze, it's now automated in about 20 seconds. The results are spit out. Now, sometimes you have to go back and tweak them a little bit, but that might take a minute or 2 minutes and not 20 minutes. So the time savings in terms of image analysis is really remarkable. And AI is having a major impact in CT imaging in terms of automated plaque analysis, where you have the potential future of personalized medicine, where you get your CT angiogram and you're told at the age of 50, male or female, how much plaque you have, what the composition of the plaque you have, and what medications might be used to optimize care down the road. Obviously, we have a long way to go before that's proven to be a benefit. I mean, it's now a pie in the sky, but this is the kind of thing that AI can do for us. We also have AI approaches to do imaging without contrast agents for so-called virtual native enhancement, which the group at Oxford that we've worked with over the last few years has developed a non-gadolinium-based contrast method combining two other types of imaging to make images that look like contrast-enhanced images, and so being able to do cardiac MRI scar imaging without contrast will be a major innovation in the years to come. But we have a question. Thank you.
Beautiful.
Sure. So, Kellyanne Lamagrury, I think one of the questions that I have is, what advice do you give the folks that are listening, and what perspective is the ACC taking with the evolution of our healthcare landscape? I mean, I think we can all say that we've seen things shifting on a dime over the last 4 to 6 weeks, and that's only going to continue to change. So how do cardiologists prepare for this changing future so that we're not reacting to it, but we're proactive and engaged in directing where it's going to go?
You know, you would have thought you were looking at my notes, because one of the things I was going to toss out there, as I mentioned yesterday in the opening session, innovation without equity is useless, for lack of a better word. And I think you're exactly right. You know, what's happening in our environment. And one of the things, those of you that have heard me talk on leadership, Chris is tired of hearing this, but the reality is we cannot control our environment. So we cannot control perhaps the chaos that is swirling around us. But what is within our power, what we must do, is to be able to adapt to it and to be very agile in how we're doing that. So I think my answer, and I'll be interested what Chris has to say, is that we must stay true to our true north. You know, I like to refer to that as our mission statement, which is equitable access for all. It's all about reducing this global burden of heart disease. There is a lot of pendulum swinging, and they swing really far one day, and hopefully they swing back the next day. We would get dizzy if we tried to follow all of that that's going on in the environment. So my hope is that we can continue to do what we do for the right reason, at the right time, in the right place, and not waver in that commitment to what we're really holding true.
Yeah, and I think I'll mention this in my convocation speech tomorrow, that, you know, resilience is an important leadership quality, and so to be able to withstand the vicissitudes of the present administration and the changes in healthcare economics, and NIH and Medicaid, et cetera, coming down the pike, I think we'll need to be resilient. We'll need to find answers, work together to move us forward rather than backward. I think the other area that I wanted to mention, and Cathie mentioned this as well, is that, you know, health equity remains the number one pillar of our new strategic plan for 2024 through 28. So we are committed to that. The ACC is committed to diversity and inclusion. We are not changing any of those goals and lofty ideals. And so despite the whirlwinds around us, we remain wedded to those true north ideals. Dr. Najam has a question.
Great.
Thank you.
So, Cathie and Chris, can you elaborate a little more? I was in a previous global session, and we've asked people how many of the people have traveled across oceans to come in and attend the ACC, and talking about collaboration. And I know, Cathie, you've insisted in the boardroom, we need metrics for global acceleration. We need to see this. Can you elaborate on this, on your vision on that, as well as Chris? How do the global society would look at the American College of Cardiology?
Thanks for that, Dr. Najman. I think that is an incredible foundation, and obviously, as I talked both at my convocation last year and a little bit at opening session, we can't do it without quality. And the thing is, Dr. Karen Joyner-Maddox talks about more brilliantly than I can, is that we can't just measure quality, we've got to do something with it. Because the reality is, in the United States specifically, we spend a lot of dollars towards healthcare, and yet where are we going? I think our global solutions for quality are something that we can continue to work on. Gaudi is one of those things that we do across the globe, which is looking at our heart attack treatment, really being able to benchmark different countries. Of course, we're a little spoiled in the U.S. with our NCDR registry and the amount of data we have, but how amazing will it be once we collect data from I think we have about 44 Gaudi sites, I think that's about right. We've just started to put out some of that data thanks to Dr. Cesar Herrera and many others that are involved in this initiative, that will help us change how we deliver care. And I know that you could probably speak to this better than I, but as we continue to work with our ministers of health, see, the U.S., we have our own healthcare system. The globe has ministers of health. We need to bring those global solutions, much like we're doing in Saudi Arabia, bring accreditation to what we do, whether it's in the cath lab or whether it's in echo, because in raising that quality across the globe, we will eventually be able to deliver a consistent standard of care, much like our guidelines, but in a more broad base into everything we do, using patient outcomes as our key driver. Chris, what did you say?
Yeah, absolutely. And the other area that we'd like to increase is our footprint around the globe, increase the number of members in number of chapters in countries around the world. We just added our 44th international chapter this week in Sri Lanka. Ireland became a chapter last year, separating from the UK, which has its own chapter. So we're up to 44 chapters. We'd like to increase our membership internationally as well. We've offered excuse me, now free membership to those under 40 internationally, and that includes not only physicians but CV team members, pharmacists, nurses, ancillary health workers in our 44 chapter countries and elsewhere. They're welcome to join under 40 free of charge.
That's great. Thank you.
Thanks, honey. Please.
Well, Jim Lee from Omron. So, question is for like the ACC traditional domain in the hospital, in clinics, you improve your quality, improve patient care, and then look on the right. There's the skill centers to train the future cardiologists, right? So, what about home? Because that's where the patients start with. And then after the hospitalization, that's where patient return. So how to improve the quality, comprehensiveness in the home care for patients who suffering the disease, getting the procedure, but enjoy life.
That is such a critical element because our sites of care are changing. And I think as we look at our hospital without walls, taking care of our patients at home, we look at cardiac rehab that we can now do at home. I think it's critical that we look at the evolution of how we deliver care. It worries me as I see us continuing to build massive hospitals, lots of bricks and mortar, as I like to call them. And in reality, our patients are really out in our communities. How do we bring that care closer to our patients out in the community? I think it was much like what you and I were fortunate enough to attend Tuesday when we came in a little bit early for the meeting, and we were doing screenings out in the south side of Chicago, compliments of Ray Kroc, who's a large philanthropy person, McDonald's, you might have heard, small organization. And it was really amazing to see the community come together, but that is just a microcosm. We have just started to begin. I mean, think about it, ladies and gentlemen. 90% of my ablations go home same day. My TAVR length of stay in my day job is 0.6 days. We are replacing aortic valves and patients are going home in a half a day. So you're absolutely right. And I don't know that we're transforming at the speed with which we really need to. I don't know that we're really utilizing the tools and the technology that we have, much less what Chris is talking about to come, that's going to do this. I think home, there could be critical care at home. You look in Brazil where they have these amazing technology and they can actually deliver care. They've got physicians in a central communications center. I mean, there was an ED doctor, there was an endocrinologist there was a cardiac. It was amazing to see what they're doing. We need to learn from our international colleagues as well as from each other how to do this, because I don't think it's that far away. Am I off base?
No, I mean, the whole hospital at home movement is very important. MedAxiom at their MedTransforum meeting, there are a number of sessions twice a year about the hospital at home movement and how you can institute such a program at your hospital or institution. So I encourage those of you who are interested in this area, improving home health care, to work with MedAxiom on in these areas.
Sir.
Hi, Ashok Krishnaswamy. I'm in Kaiser Permanente in Northern California. I'm a geriatric cardiologist, and I just wanted to ask the question regarding how ACC as a society is thinking about really aging. I'm going to kind of force that issue because we all say that we're geriatricians, but just because you take care of a 90-year-old doesn't really give you the credibility. But as a society, how are we going to think about, truly putting our money where our mouth is in this area?
Well, as the one that's aging faster than Chris, I'll take that one first. A, thank you so much for being here. B, this is something we need everybody and our CV team specifically to engage in, because the reality is we continue to spend 80% of our Medicare dollars in the last 18 months of life. What are we doing? Is that really engaging patients in a healthier, longer life, or are we just extending life? And I think this is something that we must come together and grapple with, because the reality is we're going to get older. I'd like to think I'm getting younger, but I don't think that's working. It'd be like Chris growing hair back, So I think what you're saying is absolutely correct. And how do we do that? We need to start talking about it, because end of life is difficult. We all, for some reason, want to think that somehow miraculously it's never going to end. And while we'd all like to stay here, I think we only want to stay here in a healthy way. What do we always say? I just want to keep my health. What's the most important thing is keep my health. So how are we going to do that, Chris? Because you're taking over tomorrow.
Yeah, I think we have a lot to learn from our international colleagues. We were meeting earlier today with the leadership team from Singapore, and they have a national program now to target their, I think, was it 40 or 50 years of age? I think at 50 years of age, to encourage every single inhabitant of that country to seek primary care with an aim of improving healthy or increasing healthy aging. So I think it takes a societal, it's not just going to be the ACC, I think it's going to take a larger societal push to really concentrate on treating the underlying risk factors, obesity, diabetes, all the things that are making our aging less healthy, and to move towards a more healthy aging environment.
Yeah, and I think it's just critically important that at Singapore, they are doing it financially, so they incent individuals to have a primary care, because obviously that's where the prevention's gonna come from. So in our last minute or two, if there's another question, you're more than welcome. But if not, I would like to express my amazing gratitude to the team at MedAxiom. You have been phenomenal. Thank you for allowing ACC to align with you for these Heart Talks. It's been really an amazing experience to go through the different times that I had this year in doing that. And Chris, as I said at the beginning, you've been an amazing dyad partner. You will lead us with dignity and strength, and I'm going to make sure all those tough questions come to you.
And Cathie, thank you for a tremendous year. You've been a real beacon of strength yourself, and a great example for all of us about who we can become if we just set our mind to it. So
my theme for my board this year was believe in teams. So with that, it's been a tradition. Chris and I are going to be awkward for just a second and pick up our glasses. You can toast us with your right arms, but to a healthy and wonderful 2025. Enjoy the rest of the scientific session. And to everybody, thank you so very much, and enjoy the conference. Have a good one.